Hello, and welcome to the Introduction to Kidney Transplantation at the Johns Hopkins Hospital. We're going to start by talking about why your kidneys are so important. First, they remove the waste products from the body, also known as toxins. They remove drugs and other pharmaceutical medications from the body. They balance the body's fluids. They release hormones that regulate blood pressure. They produce an active form of vitamin D that promotes strong and healthy bones, and they control the production of red blood cells. What is renal failure? Renal failure is also known as ESRD, which stands for end-stage renal disease. ESRD is caused by other health problems that have done permanent damage or harm to your kidneys over time. Most common causes of renal failure are high blood pressure, also known as hypertension, and uncontrolled diabetes. Here we're going to talk about what your options are. Today we're focusing your evaluation on the kidney transplant, but there are other options when it comes to end-stage renal disease. You could potentially be placed on dialysis. There are multiple modalities of dialysis, such as peritoneal or hemodialysis. Here we're going to talk about kidney transplantation fast facts. There are over 100,000 people that are waiting for a kidney transplant in the United States. The average waiting time for a deceased donor kidney transplant is anywhere from 3 to 6 years based on your blood type. Each year, an average of 5,000 people die while waiting for a kidney transplant, and over 20,000 kidney transplants are performed annually. In the coming weeks or months, you are going to come in for an appointment with our kidney transplant team and be evaluated for a kidney transplant. It starts with an initial evaluation. Then we will be performing some lab work and additional testing. Your case will be presented to the selection committee, and you will then be waitlisted for a kidney transplant. During your initial evaluation for a kidney transplant, you will be meeting your transplant team. The team is comprised of a number of multidisciplinary team members, such as a nephrologist that specializes in kidney transplant, a surgeon that also specializes in kidney transplant, a social worker to talk through all the psychosocial barriers that come with a kidney transplant, a nurse coordinator, a finance coordinator that focuses on your insurance, and a nutritionist to discuss the nutritional needs surrounding a kidney transplant. At this time, it would be best to save your nurse coordinator's contact information in your phone. Most of us get a lot of spam calls, so it's important that if your nurse coordinator needs to reach you, you're able to answer her phone call at any time. Please alert your coordinator if your address, phone number, or insurance changes. On this slide, we'll discuss the benefits, risks, and alternatives to receiving a kidney transplant, also known as an informed consent. The benefits include longer survival, improved quality of life, living the life without the requirements of dialysis, and overall feeling better. There are numerous risks when it comes to receiving a kidney transplant. It's a lengthy surgical procedure. You will be on lifelong immunosuppressant medication, and there's a risk of rejection, malignancy, infection, graft failure, and even death. During your evaluation, you will be doing some lab work at the conclusion of the appointment. It will include 2 copies of your blood type. Some additional testing are listed on this slide. You are not required to complete testing or consultations here at Johns Hopkins unless you're specifically instructed to do so. Please have all requested testing faxed to our office at 410-614-6906. Attention, your nurse coordinator. Here are some vaccinations that we recommend you receive prior to receiving the kidney transplant. Am I approved for a kidney transplant? Each week, the transplant team meets to discuss patients who have been evaluated and completed their necessary testing to approve them for a kidney transplant. This is called the listing meeting. Your nurse coordinator will call you with the outcome of this meeting. Once you are approved for receiving a kidney transplant, you will be listed as active or inactive. When you're actively listed, you're cleared for organ offers and you're accruing time on the wait list. When you're inactively listed, you're accruing time on the wait list, but you're not eligible for organ offers, possibly due to pending tests or current medical, financial, or psychosocial status. There are various reasons that patients are not a candidate to receive a kidney transplant. A few possible contraindications include advanced cardiopulmonary disease, severe atherosclerotic calcifications, poor functional status, active malignancy, active substance abuse, noncompliance, or a prohibitively high body mass index. Once you're actively listed for a kidney transplant, you must make certain that your blood sample, also known as your tissue typing sample, is sent to the Johns Hopkins Immunogenetics Lab. It will be determined by the transplant team how frequent your sample should be sent. Without a current sample, you could risk delay of your transplant. A letter with detailed information will follow once you are made active on the transplant list. Candidates listed for kidney transplant may be eligible to receive additional wait time on the wait list if their GFR value had previously been calculated using a race-inclusive formula instead of the current standard of using a race-neutral formula. If their eGFR value had been previously calculated using a race-inclusive formula. Race-inclusive eGFR calculations give different results for Black patients that make Black patients' kidney function look better than it is. Johns Hopkins stopped using a race-inclusive formula in 2021, but labs done prior to this change or at an outside facility may have used a race-inclusive formula. Waiting time is one of the many factors used to match organs, and having more waiting time may help you get a transplant sooner. As a kidney transplant candidate, you may qualify if you are registered as Black or African American on the OPTN kidney transplant waiting list. On a date prior to your waitlist qualifying date, you have documentation demonstrating that with a race-inclusive calculation, your eGFR was over 20, but with a race-neutral calculation, it would have been 20 or less. Your documentation will then be sent to the OPTN for review and approval of the wait time modification. Next, we're going to move into the different types of kidney transplant that you could receive. We're going to discuss live donation, deceased donation, and open versus minimally invasive, also known as robotic. How do I receive a live donor kidney transplant? Live donation fast facts. We consider live donation the gift of life. You do not need to have the same blood type to donate. 1 in 4 Americans would donate if they knew someone in need. There are multiple types of living donation. Direct donation, non-direct donation, also known as altruistic, and paired kidney donation, which is also known as the swap. How do I find a living donor? Share your story. Make a list of people to tell your story to and include friends, family, and anyone from your community. Get the word out and find yourself a champion. Share your need and post your interest in finding a living donor on your social media platforms. Encourage your friends and family to share through their social media platforms to increase the number of people that see your story. Here are a number of living donation resources for recipients: the National Kidney Foundation, the United Network of Organ Sharing, and the Donor App website. How does my donor contact Johns Hopkins? Donors can go to our website, or they can call 410-614-9345. Live donation benefits. Long-term survival is markedly improved among patients who receive a live donor kidney compared to those who remain on dialysis. When a recipient has a living donor, the wait time for transplant is shorter and the transplant can be conveniently scheduled. Live organs that are transplanted last twice as long as cadaveric organs, and live organs begin to function more quickly than cadaveric donations. Live donation frees up a cadaveric kidney for another recipient. Live donor surgery. Typically, a living donor surgery is a laparoscopic or robotic procedure. The recovery for the donor is 48 hours in the hospital. The patient is discharged home. The patient is able to return to work within 4 to 6 weeks. There are no dietary or physical activity restrictions. We just recommend a healthy diet. This slide reviews the costs associated to living donation. Here are a list of things that are covered, such as the evaluation visit, the diagnostic blood work, diagnostic testing, the surgery, and post-surgical care. Things that are not covered include travel expenses and unrelated medical conditions. What if my donor is incompatible? We're actively involved in 2 different paired kidney exchange programs: the National Kidney Registry, also known as the NKR, and the Alliance for Paired Kidney Donation. This is also referred to as the kidney swap. This occurs when a live donor is incompatible with a recipient and exchanges their kidney with another donor or recipient pair. If you're interested in living donation, for more information or to fill out an application, you can visit the website listed below or call the donor office at 410-614-9345. Typically, deceased donor kidney transplant can last an average of 11.7 years, and living donor kidney transplants can last an average of 19.2 years. How do I receive a deceased donor kidney transplant? Deceased donor kidney transplants are offered to patients on the wait list from someone who has passed away. The average wait time for a deceased donor kidney transplant is based on your blood type. Blood type O waits an average of 5 years. Blood type A waits an average of 3 years and 2 months. Blood type B waits an average of 5 years. And blood type AB waits an average of 2 years and 2 months. Allocation refers to how kidneys are distributed to recipients on the wait list. Kidneys will be offered to recipients listed at transplant centers within a 250 nautical mile fixed distance circle from the donor hospital. This reduces the geographic effects on transplant access. There are additional allocation points allotted to the recipient based on how close your transplant hospital is to the donor hospital. Here's a map of the donor hospitals that are located within a 250 nautical mile radius to the Johns Hopkins Hospital. Here we're going to discuss organ offers. You have 12 to 24 hours to get to the hospital once you're called in for an organ offer. If you're called in for an organ offer, keep in mind that a few other patients are also called in as well. There's a target patient and a backup to the target patient. At times, patients are called into the hospital for tight time constraints but later discharged. Surgeons may view the organ offer upon arrival and decide that it is not transplantable. You may be brought in as a backup and never get the organ. As a reminder, there is no penalty for declining an organ offer. Please alert your coordinator if your address, phone number, or insurance changes. Here we're going to discuss the different types of deceased donor kidney offers. First, we'll discuss High Kidney Donor Profile Index, also abbreviated as KDPI, donors with identified risk criterion, hepatitis C positive donors, and hepatitis B core positive donors. High Kidney Donor Profile Index, or KDPI, is an estimate of the quality of the kidney. It's a percentile ranking from 1 to 100%. The lower the number, the more likely it will be a better quality organ, and the organ is likely to last longer. Donor factors that are considered in this percentile ranking: age, height, weight, ethnicity, history of hypertension, history of diabetes, cause of death, serum creatinine, hepatitis C status, and donation after cardiac death. There is always a survival benefit for accepting a high kidney donor profile index kidney over waiting on the wait list while on dialysis. Donors with identified risk criterion for HIV, hepatitis C, and hepatitis B infection. A potential organ donor is considered to having risk criteria if any of the below occurred within 30 days before organ recovery: sex with a person known or suspected to have HIV, hepatitis B, or hepatitis C infection, a man who has had sex with another man, sex in exchange for money or drugs, sex with a person who had sex in exchange for money or drugs, or sex with a person who injected drugs for non-medical reasons, drug injection for non-medical reasons, incarceration for more than 72 consecutive hours, or unknown medical or social history. The long-term survival after transplant from these donors is the same as organs from donors without identified risk criteria. The potential benefit of accepting a donor with identified risk criteria is to shorten the time you have to wait for a transplant and reduce the chance that you may become too sick to be transplanted or die before receiving a transplant. The risk of missing an infection is felt to be around 1 in 10,000 to 1 in a million, depending on the risk criteria. While this risk is very low, we feel it is important for all organ recipients to know that a small risk exists, and for this reason, all recipients will be tested for these viruses after transplantation. In the very rare instance of infection transmission, effective therapies are available. The next type of donor is a hepatitis C positive donor. Advances in antiviral medications have led to a greater than 98% cure rate for hepatitis C infection. These advances, coupled with the high discard rate of organs from hepatitis C virus-positive deceased donors, has allowed transplantation of organs from hepatitis C positive donors into hepatitis C negative recipients. After transplant, recipients are treated with direct-acting antiviral medications for a period of 8 to 12 weeks to cure them of the hepatitis C transmitted from the donor. The benefits of accepting a hepatitis C positive donor are shorter waiting time and higher survival versus waiting on the kidney transplant list. The last type of donor we'll discuss today are donors exposed to hepatitis B virus. This means that the donors were exposed to hepatitis B virus in the past. There is no active hepatitis B virus. The virus, however, can be found in the liver and rarely in the blood or kidneys of the donor. There is a small risk for hepatitis B virus transmission to the recipient. These organs are offered to candidates that have been immunized or have developed antibodies against hepatitis B. Recipients are treated with medications against hepatitis B until blood tests for the virus are negative. Some other factors to consider. Signing up for all kidneys is incredibly important. KDPI is an estimate of the quality. It's a mathematical model. A kidney biopsy is performed on all kidneys, and that is the ultimate test of quality. We do nucleic acid testing, or NAT testing, which is a sensitive viral marker to determine the presence of any infectious disease. All transplant recipients will be tested for HIV, hepatitis B, and hepatitis C infection after transplantation, and should transmission occur, effective therapies are available. Are you a type 1 diabetic or a brittle type 2 diabetic? Here at Johns Hopkins, we do offer simultaneous kidney and pancreas transplantation, also known as SPK. You may qualify if you have end-stage renal disease and diabetes that is difficult to control, if your blood sugar swings from high to low, often without warning, or you have frequent admissions to the hospital for diabetic ketoacidosis. The average waiting time for a simultaneous kidney and pancreas transplant at Johns Hopkins Hospital is about 1 year, significantly shorter than a kidney transplant alone. Other types of pancreas transplants. There's pancreas transplant alone, also known as a PTA. A pancreas-only transplant is performed on patients with type 1 diabetes and no kidney problems. Pancreas after kidney transplant, also known as PAK, is for a patient that has type 1 diabetes and end-stage renal disease that gets a living donor kidney transplant. In this case, the kidney transplant is performed first using the living donor's kidney, and then the patient waits for a deceased donor pancreas to become available. What happens after I receive a kidney transplant from a live or a deceased donor? Here is a list of the new medications that you will start post-kidney transplant. You will be prescribed immunosuppressant medications. Many medications, including Cellcept and mycophenolate, can increase your risk of birth defects. Patients of reproductive potential should consult your transplant team regarding pregnancy prevention and planning. You will also be prescribed infection prophylaxis, a multivitamin, antacids, blood pressure medications, diabetes medications, diuretics, and temporary pain medications. Your recovery will be in the Zayed building on the 9 West floor. The expected length of stay is 2 to 3 days following a living donor transplant surgery and 3 to 7 days following a deceased donor transplant surgery. If your kidney has delayed graft function, you can go home on dialysis until the kidney starts working. Complications or medical issues can prolong the hospital stay. You will be assigned a post-transplant nurse coordinator. The nurse coordinator will help guide you after you're discharged post-transplantation. You'll be required to come back to the Johns Hopkins Hospital for follow-up appointments on a regularly scheduled basis, once a week, every other week, every third week, and twice a year after that. You will have frequent lab work and medication dosage monitoring by your nurse coordinator on a weekly basis. As previously mentioned, patients of reproductive potential should consult their transplant team prior to pregnancy due to the increased risk of birth defects while taking the immunosuppressive medications. Delayed graft function is when the patient has low urine output and the need for dialysis within the first week after transplant. It can occur in about 50% of deceased donor kidney transplant recipients. The most common donor and recipient risk factors include high donor creatinine, low donor urine output at the time of transplant, long out-of-body time on ice, and low blood pressure of the recipient during the transplant or thereafter. So what happens next? You will be evaluated by the medical, surgical, and psychosocial team. Your nurse coordinator will arrange for necessary testing to determine your eligibility. Your case will then be presented to the selection committee, and if medically and socially acceptable, you will be listed for a kidney transplant. In the meantime, find a living donor. During your initial evaluation, you will review this presentation with your nurse coordinator and sign this slide. Thank you for choosing Johns Hopkins for your care.